Good to see some familiar faces, and I'm delighted you're here for the recovering from painful shoulder issues without medications, drugs, or surgeries. This is a topic that's near and dear to my heart, and I'll tell some stories, I'll give you some information from a slide presentation, and I'm more than happy to hear about what brought you to the workshop, so that I'm sure to include some information that you'll find valuable when you leave tonight. So the format of the talk is like this.
We wanted the air, but we don't want the noise.
Sounds like North Main Street.
That's usually not so active on this road, but last grasp at summer weather, I think. So, format of this will be, I'll introduce myself from the standpoint of, so you know who's in front of you and what our perspective here is. I'll be delighted to hear a bit about you. I'll present some background information about shoulders, and go through a list of common things that are likely going on in individuals who tend to come to these. We'll talk about what solutions look like, and one of the funnest parts of the night is what we call a 5-minute miracle, and that's a chance for us to see what an assessment and trial treatment, mini treatment might look like for someone suffering from shoulder trouble, so that you can see that it's not overly scary. Basically, and then we'll let you know what next best steps are if you guys want to pursue any other options. So, a couple of house cleaning things. There's a restroom 2 doors down the hallway this way. There's a restroom straight across the hall and to the right. And if anybody can't hear me, let me know. What?
I'll just turn you up.
What?
Turn you to deaf ears, you say?
Right. So, all right. So we'll get going here. So, so at Physical Achievement Center, we help people achieve greater mobility and strength for their active life without medication, drugs, or surgery, and even when nothing else has worked. We've been putting on seminars like this for 5 years. The shoulder one comes up about once every 3 months. A little bit about myself, for those that you don't know me. I've been in practice for well over 30 years now. Nearly all of those were in Oshkosh in multiple facilities, multiple places. I had the privilege of training as a fellow of the American Academy of Orthopedic and Manual Physical Therapies, which means nothing to everybody here other than it was a chance to dive into the research, what's effective for pain relief from head to toe, and also learn terrific practical applications of how to help people who present to us in the clinic every day. And you rack up a few treatment cases over that time. There's other providers here as well. Dr. Rebecca joined our team over a year ago. She's got over 10 years of experience. She's got a specialty in applied Gary Gray science. Cool way of looking at how the body parts affect each other from head to the ground. All of our clinicians are going to go get additional training in that in Chicago in 3 weekends. And she has helped a considerable number of folks. She was voted a physical therapist of the year in Wisconsin in 2019. And some of you may have had a chance to work with her and know how helpful she is, and what a terrific clinician and person she is. Dr. Jessica's the most recent addition to our team. She is a graduate of Marquette University. She's certified in vestibular or inner ear systems, specializes in dizziness and balance. She is certified in dry needling, and she's terrific as well. Gina's a physical therapist assistant. She's been with us since the first of the year, and she has got advanced training in pain relief and sports recovery massage, certified shoulder and certified spine specialist. Lori Shates, a couple of you know, she was the first call that I made when I decided to open up a practice. I've known her for well over 20 years. She's a fierce patient advocate, and she's really interested in holistic care. I don't know if as you're coming up, she was actually leading a group of individuals on a walking group, people who have lymphedema issues, those folks that are in her caseload. She's a specialist in that area. She's an occupational therapist. So that's a bit about the providers, right? This isn't about us necessarily, but you should know who's in front of you. Bottom line is we want to help real people with real problems. We want to be a source for individuals when they want a second opinion or when they're really struggling with what they're being told. And as it pertains to shoulders, we'll talk about a particular study that really changed my clinical practice. And actually was the start of why I started the practice. And just for background, I worked for over 20 years at the state of Wisconsin. I was a physical therapist at Winnebago Mental Health Institute, 4 mornings a week. Great setting, learned a lot. Outside of there, I did a lot of things. But I remember very clearly, I read a study that came out in 2013, and we're going to talk about that study tonight. It was about shoulder and rotator cuff issues. And so the study came out and basically said that for those individuals who have a rotator cuff tear, a full thickness rotator cuff tear, and we'll talk about that. Previous to this, everyone presumed that if you have a rotator cuff tear that you need a surgical repair of that. That was common understanding amongst primary care providers. It was the communication that came from the orthopedist. It was a common understanding of physical therapists. Again, 2013, nearly 10 years ago. Well, this study came out, and it was in a top-tier orthopedic journal, the Journal of Shoulder and Elbow Surgery, by Dr. Kuhn. It was a multi-clinic trial. It was in 5 centers throughout the United States, and people were divided into 2 groups. Those that were assigned a particular protocol, we're going to talk about that involves hands-on treatment and exercise protocol, and those that went to surgery. The spoiler alert is, at 2 years, you couldn't distinguish the 2 outcomes. In other words, over 70% of individuals who did not have surgery did just fine. Now, if that was a one-off study, that would have been one thing, but that study was replicated all over the U.S. multiple times across the world to the same conclusion. So I thought to myself at the time that first of all, I need to change my communications with the patients. I need to offer my patients options that don't just include, well, we'll see what you can do, maybe, and you'll likely have surgery, right? My communication needed to change. Secondly, I anticipated that physical therapists would be using this research to advocate for non-surgical care, because that's our specialty. And thirdly, I anticipated that the practice of orthopedists and primary care providers would change, particularly as the evidence continued to mount time and time again. Sad to say, that didn't happen, right? To this day, there's still this understanding that you're kind of like not going to get a good outcome unless you have that surgery, right? So, and that's despite really good evidence and despite good clinical outcomes that I've seen through my career. So it's been instances like that have really shaped my understanding of how we need to change our game and how we help people provide other options. And that's kind of what led to the genesis of the clinic. So I get out of fellowship training and I think to myself, yeah, the way that I communicate with patients is pretty straightforward. We have adult conversations, we talk about the research, and I'm not really trying to placate any group. Like, I don't have a physician group that I need to satisfy, or I don't have an administration that tells me I can say or not say certain things. So that's why I started the clinic, to have an independent voice for what I believe are options for individuals, and people can do that what they will, right? So basically, we want to help people make better decisions about their health care, and be a source for natural pain relief without things like the first reaction, medications, drugs, and surgery, right? Here's some pictures of the rest of the team. We've got some new team members. You met Robin and Megan as well, perhaps coming in. So we want to be the source of information and inspiration, and I can tell you I'd have issues if some of my staff had conversations like this, like we will never tell anybody, like, what do you expect? It's your age.
Oh yeah.
Like, I can't, if you can't help somebody, just say you don't know how to help them, right? I mean, don't throw the age thing out there, right? It's personal to me because I'm approaching ages that, you know how it is, each successive year, you're like, gee, how did I get to be this old, right? And I certainly will not be pleased to hear stuff like that if I'm presented to providers. There are some age-related changes. Pain and disability is not one of those things we should presume that just should happen. You just have to live with it, or, you know, some simplistic model here. So that's a little bit about me. I want to know a bit more about you, and I want to also grab a shoulder model. So give me one moment, and I'll grab that shoulder model because I'll be talking about it shortly. I'll be right with you.
So we're all hoping he won't ask us to raise our hand.
I haven't been attending because I couldn't get
All right, so so that I know that I can address things that are important to you, I would appreciate if you could just state your first name and what concern and worry brings you to the presentation tonight, so that I'm sure to include some content that's relative to what's going on. So it'd be kind of like this. Hi, I'm Eric. I'm an alcoholic. No, just something simple. Hey, look, I'm concerned about this. I've got this. Not looking for necessarily a long medical history, but just what sort of worry and concern that brings you to the presentation, if you don't mind.
Sure.
You could lead us off.
I'm Tracy, and I hurt everywhere, but especially there.
Okay. What's your biggest concern and worry?
When I'm walking him, so that if there's a time when he were to pull, that I feel like my arms are gonna fall off. I don't feel like because I've always had low collagen, and so I dislocate easily.
Okay.
So that's a huge thing for me.
Okay. So if we don't talk about over flexible joints, chime up and we'll be sure to talk about it. Okay. Thank you. Yes.
I'm Kim, and I have some limited mobility in my shoulders, kind of stemming from the traps area, and it's affecting my yoga practice.
Are you practice or you teach or both?
I practice.
Okay.
Mhm.
It's getting serious.
And my yoga teacher came here and got help, so.
Okay. Miss Deb?
Miss Deb.
Yes.
Yes.
Awesome. Perfect. All right. Yes.
Yes, hello Eric, I see you again.
Yes. Welcome.
This time it's my upper extremities, and for the past year, I've had to help my husband in and out of his hospital bed or chair, and so I'm pulling a lot, and a year ago, I actually did something bad to my shoulder to the point where if I want to turn the the steering wheel, it hurts to do that. Last June, July, and August, 15 times I saw a physical therapist through Ascension. Didn't help. I probably felt a little better at the time when I was doing it. We've used tape. I've used pads with medicine in it, and talked about injections, which I don't want, and talked about surgery, which we didn't think it needed, but it's not easy to live with this, considering I'm still my husband's major caregiver. On top of everything else you know about me.
You've got some considerations. You want to continue to be useful for your husband.
Well, not for me.
And yourself.
I want to outlive him.
I only understand.
There we go.
You want to have a chance to enjoy life again. It's at a different level. You're enjoying with him.
Say about
Right.
Jennifer, and I just am experiencing pain in the back of my arm, shoulder, don't know what. I think I sleep on it all the time now. That's it.
Does it disturb your sleep too?
I don't think so.
No? Okay.
But I want to catch it real quick. It's
Fair
really
enough.
bad.
Fair enough. Perfect.
I'm up. My name is Bill, and well, maybe the last month or so, I've been experiencing a little, minor pain in my right shoulder. I don't know what's going on with it, but, you know, in the past, my history, I've had 2 broken collarbones over the years, but I don't know if that's part of the problem, but either that or I've been doing something that I've been overworking that particular right shoulder, but it's not a lot of pain, but just kind of like a little minor toothache. I think it's more of a strain than anything else. I don't think it's a rotator cuff problem, but that's what I'm in for.
Okay, thanks.
My name's Maureen, and I'm here to support him, and I have another pair of ears. And just to learn, I'm a retired nurse, and I just want to learn more about the shoulders and what's you're doing now to prevent surgeries. I have several friends that have had the reverse shoulder replacement, and I want to see what the other options are. I know sometimes that is a last resort, but not always. Not a first resort.
I have some allergies and it's driving me crazy, so.
Yeah, Mary Ellen, and about a year and a half ago, I had impingement surgery on the shoulder, and think I got through physical therapy well, but I just want to make sure that I'm doing what I need to do to keep them in good shape. So,
Okay.
yeah, pretty simple.
Thanks, Mary Ellen.
I'll get better, right? Hips and shoulders, I had kind of a frozen shoulder, and I've been working with my doctor with physical therapy, getting that, it seems like it always closes down. There's a lot of arthritis, inflammatory arthritis and with the hips, and so just looking at different options, because I don't want to take a lot of medicine.
Got it. Okay, thanks. Yes.
I'm Scott. As a senior in varsity football, high school, separated that shoulder. It never got a pin in it, so it hangs lower anyway, but it's always, you know, well, not always. There's times it hurts worse than other times. And I don't know why, but for some reason, the other side gives me a little grief every once in a while. I don't know if it's because I rely more on that side than this side or what, but here, learn how to get rid of that problem.
Fair enough, thanks.
Hi, I'm Joanne, his other half, and I do have shoulder issues. I've had a lot of body injuries being helped by you all, but I have like cracking going on, and I don't know if it's arthritis or just because of the injury, you know, shoulder injury. So I just want to figure out what else I can do besides what I'm doing.
Okay,
If
thanks.
there's anything else I can add.
For sure, thanks. Hi.
Hi, I'm Sandy. I did have rotator cuff surgery a couple years ago, and I have been helped greatly by dry needling in my other shoulder. So I'm just here to find out what else, I can do, so.
Perfect. Thanks.
Hey, Brad. Got a motorcycle back. Motorcycle accident back in August. Took the windshield to the neck, and I've got impingement in my neck and my shoulders hurt. I have problems sleeping. I'm not getting anywhere with chiropractor and a doctor, so.
Got it. Okay. Thanks.
Name's Christian. Fell down some steps about 6 months ago. I think I tore a rotator cuff. I'm not 100% sure. Limited mobility. Some things like unable to move my arm in places it should go. So here to learn more.
My name is Teresa, and I'm currently seeing Eric right now. There's some calcifications in my shoulder and nerve impingement from an old injury and some tendon degeneration. So he's been helping with dry needling and other types of therapy and nutrition and things like that, so I can rest better at night, and so far so good. That's it.
Diana, and my job is quite strenuous. I do a lot of pushing and pulling 300-pound rolls. My shoulder is painful 24/7. I take lots and lots of pills. But now the pain runs up around the back of my ears. So I don't know if something's just stretched to a point where it doesn't want to go back, because every day I have to do this. I do 60-hour work weeks, and it's strenuous. So I'm just trying to figure out something to help me.
Thanks, Sharon.
Jason, I have the shoulder issue, mobility-wise, certain movements set it off, like a lot of pain. Maybe stem from neck injury from the past. I'm just looking to see what different options there are. I've already been through quite a bit of physical therapy, and I've already seen an orthopedic, and I'm afraid that the next step would be surgery, and I don't really want to go there.
Got it. Okay, fair enough. All right, well, thank you, everyone. Like I say, if I'm going through the discussion tonight and I'm not covering a topic that's included here, I'm hearing a bit of over flexible shoulders. We'll talk a little bit about that. But I think we'll have a talk that's inclusive of what most people might be experiencing, or at least partially. So we'll get into the things that can go, basic anatomy and things that can go wrong with shoulders. So first of all, we're going to talk about some basic anatomy. Rotator cuff is a oftentimes poorly understood and kind of discussion that once it comes up, people, a lot of fear and worry goes into it. We want to demystify it and explain what the rotator cuff is, how it relates to shoulder functioning, as a means to help understand some of the things that can go wrong with the shoulder joint. So the rotator cuff muscles is a series of shoulder muscles, and I'll click through the presentation slides in a little bit, but this happens to be a model of a right shoulder. So this is as if this would come off of me, just like this, right? This is the collarbone in front, so the collarbone rests on the breastbone, the sternum here, and comes over and forms the acromioclavicular joint. Then if you do the chicken dance, you'll feel a bigger indent there. There's a bit of movement that occurs there. The shoulder blade is where the rotator cuff muscles insert into, and then the upper arm inserts into that. I'm going to pass this model around. From a bony connection, there's a small round upper end of the upper arm bone that fits into, and open this up a little bit and look in a very small area for that ball to rest on. That's called the glenoid fossa. It's kind of like a softball sitting on a golf tee, right? So there are some structures that help keep that in place, and primarily it's muscular support. Muscular support from a series of muscles that you see in red. These muscles represent the rotator cuff muscles. From the back, there's a supraspinatus and infraspinatus muscle. There's this little muscle down here called the teres minor. You have to make things complicated. I think it's to help increase our charge rate. I'm not quite sure, but that's the names of them. But it's basically above the spinal scapula, below the spinal scapula, and then a small muscle here. Those are counterbalanced with a muscle on the front called your subscapularis. So those muscles form a sling that holds the upper arm on, and those are deep muscles to the shoulder. I always liken these to the behind-the-scenes action of a performance company, right? Like if you go to see a show, like at the Grand, right? There's stuff that goes on that when it goes well, you don't even realize they're there. The sound and the lighting, you know, and the staging. If they don't show up, nothing gets done, right? And you don't really see them, right? It's kind of like that. Those are the deep muscles, and their purpose is to act all the time while we're doing large movements. So these muscles we don't see on well-developed bodybuilders. Like nobody flexes their supraspinatus and says, that's an impressive supraspinatus. The overlying muscles of the large muscles, the chest, the deltoid, the lat muscle, biceps, triceps, those are the big moving muscles. If the rotator cuff muscles don't do their job, those large muscles have a hard time functioning, because as you raise your arm and move, there's supposed to be a particular relationship with that arm, upper arm to that shoulder blade that remains intact, and those muscles keep that relationship going. That's the function of the rotator cuff muscle. And discussions
There's
of
no
that.
muscle in there.
The muscles are represented by these.
So there's no muscle in here.
There's no muscle at where the bending occurs, right? Yeah. It's kind of like the hand through the wrist area. There's just tendons. There's no muscles at the wrist area. All the muscles are in the forearm, because otherwise your hand would be like a big club, right? So it's got to be refined. So the muscle bellies, there's no muscle bellies here, but it's simply the tendons, what the muscle uses to insert into bone, forms the joint capsule. And we're going to talk a lot about joint capsule because it's one of the least discussed and probably one of the most important structures, physical structures, to help determine function in any joint, particularly the shoulder joint. So that's a little bit about the rotator cuff muscle, rotator cuff, if you will. You can play with that a little bit, and I'll pass that around. So that's not the only thing we'll talk about, but I think it's important to understand that. Here's a couple of illustrations of that. There's a supraspinatus, infraspinatus, as we talked about, teres minor, subscapularis, and when I talked about that one study, there was the understanding that when you had a problem in the rotator cuff, that maybe, good luck, you might get some recovery. You're probably going to need surgery. A couple things are becoming apparent now. That research is starting to become more readily understood by insurance companies, and also people realize that surgical procedures to the rotator cuff, that's a prolonged recovery, right? And that's not always an assured recovery outcome, right? So there's a whole kinds of pitfalls that occur with that. But it's always important to understand how that rotator cuff muscle functions, because if someone wants to maintain shoulder use across their lifespan, they're well served to think about that as part of a strengthening ritual several times a week. Like, how do I keep my rotator cuff muscle strong so that despite my age or activity level, I can have some good motor control and reach up overhead? How do I take care of that, right? So we'll talk a little bit about that. So none of you are making big mistakes about your shoulder and rotator cuff problems. You're doing something, you're getting educated, that's great. And if the longer something sticks around, the peskier things can be, because more things tend to adapt and maladapt to problems. So no one's served well by waiting to get problems taken care of. If it doesn't recover in a normal time frame, several weeks to a month or two, it's probably time to get some attention for it. That's kind of the bottom line. Spending time in approaches that aren't getting you closer to your solution is probably not overly helpful. There's lots of people who take over-the-counter pain medications, who do maybe some ongoing ointments and that sort of thing. Bottom line, if you're not getting better week by week, month over month, you're spinning your wheels and you're wasting valuable time that could be spent on getting better. We used to think that over-the-counter medications like non-steroidal anti-inflammatories were just like, oh, you can just kind of take them and there's no side effects from that. We've got some nurses in the crowd, and we've got other folks who probably read a little bit. What are some problems with even over-the-counter non-steroidal anti-inflammatories?
You lose your liver. My cousin couldn't make it to our wedding because he'd take it either leave or the other one with an A. And he had no liver left. His wife donated part of hers.
Wow. So that's a example, but side effect is liver stress.
Yeah, and all NSAID bother the liver, period.
Right. I had a friend up north, his lady friend at the time, she would pop those things like they're like Tic Tacs, right? Thank you. It's crazy. That's a lot going on here. And she ended up, she had a stomach ulcer, and she was probably two days from death had she not been taken to the hospital. Cardiovascular risks with those, elevated cardiovascular risk with those, and of course kidney stress, right? So they're not innocuous. I'm not painting shade on them. It's just that if you're taking a lot of those, boy, maybe it's time to find some alternative way of doing that. Of course, the
even aspirin has a problem. Could eat a hole in the gut.
The disaster of the opioids. I was in healthcare during the setup for the opioid epidemic, in which opioids were touted as a safe and effective approach for long-term pain management. And we know that opioids are neither effective for long-term pain nor are they safe, right? Disastrous effects occur. We don't know who gets addicted to the opioids. It's not discriminant upon socioeconomic status. It's not discriminant upon age, sex. So there's some pitfalls to some of those overlying. Muscle relaxants, you know, they can challenge your nervous system. They're a nervous system depressant. Oftentimes people use those to help sleep. That's terrific. I'm a huge advocate of getting restorative sleep, but that presents some secondary problems with sedation at night, particularly with risk of losing balance if we're getting up, going to the bathroom, or being off kilter in the morning. So another mistake that folks make is to ignore what I call holistic. I'm not thinking holistic from the standpoint of like chakras and incense and all that kind of stuff, right? I'm talking holistic in terms of a comprehensive approach, and we'll talk about that. And one of the reasons that I'm really proud to be in the profession, to offer the sort of things that we can as a modern evidence-based doctor of physical therapy. There's no need to use a singular approach, right? And that's what that's talking about. And then relying exclusively on surgery or injections to getting back to your active life. Some people go to surgery, right? Some people have that option, and I'm not about taking away people's choices. I just think if you're going to have a surgical procedure, you want to enter that surgery knowing that you've either A, exhausted conservative intervention, right? Or B, you prepared yourself for that surgery and done some prehabilitation, or at the very least on the backside of that, you've done some good rehabilitation so that you're set up for long-term success. Corticosteroids, steroid injections, they can relieve pain and inflammation very abruptly and lower inflammation. People get tremendous pain relief with that. There's a couple problems with steroid injections, one of which it thins out tissues, including cartilage tissue. It thins out underlying bone tissue, and it's not recommended to be done very often for a particular reason. And it's quickly becoming well known that it also can increase risk for individuals who might be susceptible to diabetes. That can affect insulin levels. So if one's going to be using some of those activities, particularly the injections, a good opportunity then, within 2 weeks, get in and get after it. There's some things that probably brought that shoulder to problems. If you have the injection, look, you manage that inflammation, you've tampered down that pain a little bit, might be a good chance to look at other solutions to make sure that it doesn't come back again, rather than just, oh, let's just see if it comes back, right? Let's treat it functionally. So I'll move ahead. So I took a course once. My boys were in Scouts, and I took adult leadership training and Wood Badge, and one of the funnest classes ever was Wilderness First Aid. I thought, this is great, Wilderness First Aid. Well, one of the things when you take Wilderness First Aid, you don't realize the sort of things you might encounter, right? Like one of them was, I know how to treat, and I hope I never have to do this, I know how to treat an impalement in the eye in the wilderness. Like I'm thinking, yeah, that stuff can happen, right? Like, I would rather not, but you learn about the sort of things that could happen. You want to be prepared. Discussion like this, there's a lot of things that can contribute to shoulder problems. This is a sample, right? This is a sample. I think we talked nearly about a dozen of these, and these tend to be common in individuals and oftentimes not overly understood. So the first one, we're going to start off with a bang, and this is what I talked about: stiffness in the rotator cuff joint. So this is common. We're going to talk about things that might be signs of this. People who have stiffness to the point where maybe they have a hard time reaching into their back pocket. Might seem like it's frozen, like they have a hard time raising it up, feel stiff. Generally, it's better at your side. Like, you know, if I keep my arm still, it's not too bad, but I start to move it, it starts to feel stiff. And what that represents is this connective tissue that forms this joint capsule, just like any joint that has fluid in it. It's called a synovial joint. Well, that connective tissue, in the presence of inflammation, will get tight. Ordinarily, there's lots of flexibility in that shoulder joint. So in a natural shoulder that's feeling good, there's lots of give. We can have some movements here, but in the presence of inflammation for a period of time, all those tissues stiffen up, and the joint capsule becomes hardened and immovable. An extreme example would be frozen shoulder. Less extreme examples are just, hey, it's stiff. So in other words, if that joint capsule is stiff, it doesn't have the normal flexibility. So people reach up and, ooh, that's painful. Ooh, that's painful. This is painful. You can put some dumbbells or pressure and push and pull all you want and try to build muscle there, but if there's a movement restriction, that movement restriction's got to get taken care of. The beautiful thing about joint capsules is they contain the cells that produce the joint lubrication for that shoulder joint. So we hear this saying that motion is lotion. Well, natural motion in any joint helps to keep inflammation from building up in a joint, and it also helps to produce the joint lubrication fluid so that you get a natural way to change the oil in your joints, right? We take a car in every 3,000 to 6,000 miles. 6,000 maybe if it's synthetic oil, right? But normal motion helps to keep that changeover naturally. So restoring that normal flexibility is helpful in that shoulder joint capsule. So that's one issue that happens and is fairly common. Tendon weakness. This is where that tendon, and tendons are what muscles use to connect to bone. Tendons can become weak, and that's called tendinopathy. Oftentimes there's a term thrown out, tendinitis, and that is when the tendon is inflamed. Itis means inflammation. Tendinopathy is where, if you remember looking at this, these fibers here are all kind of parallel, they go in the same direction. Tendinopathy is where there'll be thinning and wearing of those, and instead of being parallel to the forces on there, they'll become very irregular. And that's called tendinopathy. That's a condition that might be going on in individuals who have a weakened tissue, and it may not just be inflammation. Pain with lifting, pain handling objects. It might just seem overall weak. And it's not necessarily associated with any sort of abrupt inflammation. There's no puffiness there. So that's tendinopathy. Irritated shoulder area nerves. So there's a number of nerves in and around the shoulder that can become irritated in and of themselves. You have, obviously the bones, you have the joints, and you have nerves around that area, and those nerves can become hair triggered. That becomes its own entity. So an example of irritated nerve function would be as if a little bit of activity seems to irritate that area for a long period of time. Like normally if you think, hey, I'm gonna go out raking or something like that, I might be bothered for a little bit into the next day. But in this instance, shoulders get a very little use and they're irritated for 2 or 3 days because it takes a long time for those nerves to calm down. So that might be a clue that someone has some irritated nerves in the shoulder area. So that nerve pain might last for more than 48 hours with low-level use. That'll be associated with, and some of you talked about, hey, it seems like I get this stuff along the side of the neck. Irritated shoulder nerve areas can be associated with irritated neck nerves, and we'll talk about that as well. These things will not show up on X-ray, MRIs, or CT scans, just because Oftentimes we, when there's scans or even physical examination, they'll point and direct things to where the yowie is. And most of the time the yowie and shoulders tends to be about where the shirt meets the sleeve. But there's a lot that goes to shoulder function, as you'll start to see. That just happens to be the effect of things, but it's not where oftentimes the main areas are. This is best detected with proper physical examination and especially a history. So when we say history, that means listening to individuals' development of symptoms over time and understanding what sort of things might bring about their symptoms, what sort of things might calm their symptoms down, starts to build a case for one of these types of conditions. True shoulder weakness is probably also associated with general weakness. These individuals just maybe feel weak all over in any number of areas. The body needs a certain amount of firepower in their muscles in order to do things like push, pull, and lift. True weakness is when, hey, you know what? Got this issue where maybe I'm not involved in the right type of strength and conditioning, and I don't talk about age a whole lot other than with each successive decade of life, without proper type of exercise conditioning, your muscle power goes down a little bit if you don't have some sort of plan, right? Individuals have different levels of muscle strength to begin with. Generally, guys have more robust muscle strength than ladies. There can be individuals who are really robustly strong, naturally, who maybe are a little more protective. But as I always say to individuals, at some point, if you're on the planet long enough, God willing, you're going to be subject to a point where you're going to run out of good luck in genetics, right? Like those muscles need some development. So true weakness might be general. Somebody who has maybe a more sudden loss of strength, where it seems like, you know what, I just can't do that anymore. Maybe associated with a rotator cuff tear or some sort of pain. And basically someone's not doing the sort of things day in and day out like they're used to. Think about it like this, like in fall, we do a lot of yard work. Summer, we're coming off of yard care. And if we don't do things like shoveling over the winter or some sort of exercise plan, okay, now we go into spring, our bodies have been on vacation for a while. We try to get back at that gardening stuff, lifting 20, 30-pound containers or doing a lot of shoveling. That requires a lot of strength, and if our muscles have been dormant, that might catch up with us. True weakness generally doesn't show up on X-ray, CT, or MRI scans. Can only be detected with proper physical examination and history. So we're going to talk a little bit about some of the things that go wrong. We'll talk a little bit more, but getting on the topic of muscles, this is some research that is well understood about the nature of what MRIs show and don't show. So I had the privilege of entering the physical therapy profession at the advent of MRIs. We do not want to live without them. We want them to be available, but they present some challenges for interpretation that involve a deeper story, and we're going to talk a little bit about that. So this is a study from before the turn of the century, and it shows something called asymptomatic rotator cuff tears with age. So as part of my project and fellowship, I delved into this literature very deeply, and we're going to describe this. So asymptomatic means don't have any symptoms. So there's a collection of MRIs from people who might be getting an MRI of their chest wall or some sort of condition, and by the way, they capture a view of the shoulder. These individuals don't have any sort of pain, and they take a look. Are there abnormalities in people's shoulders who don't have any pain? And this is average population. What they show is individuals between 50 in their 50s, in their 60s, in their 70s, and their 80s. This is one of the most conservative discussions about the incidence of full-thickness rotator cuff tears. These are radiologists, these are medical journals, these aren't opinions, these are scans. What they find is that in the 50s, at least 13% of individuals have at least one or more full-thickness rotator cuff tears. That's through the whole area. They don't have any problems. Thank you very much.
Wow.
In the 60s, it goes to 20%. In the 70s, it goes to 31%. And in the 80s, it goes to 50%. Most studies show the incidence at higher than this. This is age 50 plus. This type of research has been replicated all over the world, in every continent, and in athletic population and non-athletic population. In other words, that there is a high prevalence of tears in the rotator cuff that may just not be of any consequence for most individuals, that need to be considered when we're talking about and trying to plan out for shoulder treatment. Here's another one. This is a little bit studying the effect of this. Early before this study, and this is the reference study, full thickness tears. Exercise significantly reduces the need for surgery, more than 75% of the time at 2 years. That's another aspect of it, right? That we don't have to only be assigned as the only option shoulder surgery when it comes to rotator cuff tears. This is an earlier study, or actually later study, rotator cuff partial thickness tears. Exercise is effective as surgery, and this is really interesting at a fraction of the cost of the surgery, right? So a lot of people have insurances, they'll cover surgery one way or another. Oftentimes, I'm no fan of insurance companies, but oftentimes insurance companies will say, hey, look, maybe you should go to a little bit of therapy first, right? When individuals come in for that, they're like, you know what, I gotta come in and my insurance companies make me come to therapy. I want my surgery, why am I doing this? It's one of the few times the insurance company are trying to do you a favor. They're trying to say, hey, look, their folks read this medical research too, and they're trying to avail themselves to doing something that's going to be potentially less costly and less risky. Oftentimes people have a bias towards, hey, I really want surgery. Why are they making me goof around with this stuff? And I get this, because that's part of the decision process too, is what is a patient's preference. But certainly this research is out there multiple times. So it's interesting to me, and I haven't updated the presentation, what's becoming really commonplace now is a discussion for, instead of rotator cuff surgeries, what's the surgery that's advocated more often now?
The total reverse?
Total reverse shoulder surgery. And
What does that mean?
well, I'll tell you what it is.
Without passing out.
No, it's so. Here's the thing. The shoulder joint has a cup in the that receives the upper arm bone, and there needs to be roll, spin, and slide. A shoulder joint like this is hard to replace with function. So what they do is they make this the cup, and they put a ball on the shoulder, on the scapula, so that the muscles can function better. They tend to leave the muscles a little bit more intact, but it's still an invasive surgery. What I'm noticing, and I don't understand it, and I don't necessarily, I'm not an expert in this, and I don't do the rotator cuff surgeries, but I can tell you what's happening now is orthopedists in this area, and this may be a phenomenon across the country, I don't know, are oftentimes recommending total shoulder reverse surgeries before anything else. The last shoulder presentation I had, there wasn't as many people as here. There was 4 individuals who that's all they were offered. It's like, well, you've got some arthritis in the shoulder. Let's do a total reverse shoulder. Now I find that really curious for a number of reasons. I find it encouraging though. I find it encouraging because, number one, the public understanding of the problems with rotator cuff tear surgeries is becoming more commonplace, right? So people understand that rotator cuff surgeries aren't all that glorious. It's long recovery. So number two, I'm finding that there's the research that doesn't support rotator cuff surgeries to the extent that it had been offered. Number three is there's not a lot of long-term studies about reverse total shoulders. Now, some individuals do well with them, some individuals don't do all that well with it. I have not seen any research that is convincing that says that is a fantastic surgery that gets superb results for everybody. So, but there's one indication for that that might be really advanced arthritis. That's going to be for somebody like these people we know. These are folks who have really advanced arthritis. They move and you can hear them creak from across the room. They have really thickened joints. I mean, you know that thing has, the structure of that shoulder has really changed. And that might be a good candidate for that. Definitively, but for whatever reason right now they're being offered pretty readily for individuals without options and discussions about conservative care. And that's why I bring this up, because I talk about other things that contribute to shoulder pain. One is shoulder arthritis. And the takeaway is pain and weakness isn't always a result of the arthritis. In other words, when you properly manage the joint, when you strengthen the muscles around it, oftentimes you can get significant improvement in flexibility, significant improvement in strength, and you don't necessarily have to assign yourself to pain and stiffness, and you don't have to just assign yourself to corticosteroid injections or surgery. Basically pointing to conservative care, non-surgical care can be really effective with that. Frozen shoulder. Frozen shoulder is a special case called adhesive capsulitis. Anybody here have a frozen shoulder or been told they have a frozen shoulder? Yeah. Not fun.
So does that
Basically, the connective tissue in the ball and socket joint, this becomes really adhered down. Ordinarily, underneath here, there's little flaps like an accordion, and when you raise your arm up, those accordion pleats open up. In the presence of true frozen shoulder, those accordion pleats get seized together. We don't always know why it happens. It can be because the shoulder's just painful and inflamed. Sometimes we believe there's a hormonal influence. There's a really, it's like 5 times more likely in women than men. Tends to be peri and postmenopause women that are a little bit more at risk for it. It can just develop all of a sudden on its own, but it's also called adhesive capsulitis. If you do a Google search on this, a couple things that generally doesn't show up on a CT scan or MRI. A good physical examination will reveal this. It's pretty apparent. If you Dr. Google this, anybody Google frozen shoulder and what the recovery looks like? Anybody? They'll tell you things like, oh, you know what? It'll go away on its own in less than 2 years. That was the belief and research from over 10 years ago. Recent research shows that people get a little bit better on their own, and then basically they stop going to their doctors for it because they start to compensate by doing things like, oh, if I can only reach up like this, well then I'm going to give a little bit of English and do this. I'm going to put stuff at lower levels. I'm going to use my other hand. I'm going to get a reacher, right? So people adapt to it, but they don't recover from it without conservative intervention. So that's why I say it will not unthaw and get better on its own typically. There are cases where it will, but those are rare. You hear those rare cases where I had my frozen shoulder and then I slid off the roof and I grabbed the eave and I felt the tear and I never felt better. You hear weird cases like that, I wouldn't recommend that as a treatment, right? This could take a while to get better. And people need to kind of work at this on a regular basis to not overstretch it, but also to stretch it on a regular basis and keep working at it.
Yes.
Right, it's kind of a rhetorical question. We didn't talk about
Other stuff.
well, we didn't talk. There's other things that can go wrong with the shoulder too, right? So there's a couple people that talked about shoulders that are too sloppy, right? Shoulders that have too much flexibility in that shoulder joint, and that can become an issue too. There's certain conditions, like generally it's well known that women have a little bit more flexibility in joints than men. One good thing about getting older is that day by day our tissues tighten up a little bit more. So if you do have a tendency for excessive flexibility, and there are individuals like that, that tends to lessen over time. However, when it comes to shoulder, typically that means that shoulder is just irritated and you might have dual things, like things stiffen up around the shoulder, but you still have a shoulder that's sloppy. Anybody that's got a shoulder that moves around too much, like it feels like they're shifting and moving around the shoulder joint, they're probably being accurate, right? that our ability to feel that joint move around a lot is pretty precise. And that's an area that's worthwhile consideration. It's not as common in the type of age group that tends to show up for these discussions, so I don't talk about it a whole lot, but certainly in physical examination, we will address it and discuss it. So is it possible to have more than one thing at a time? Yes, right? So early on in my career, I was pretty ambitious. I set aside time and effort and would go and learn different techniques. That was in the era of what we called guru medicine back in the day, where, oh, I go learn from this guy or gal, I'm gonna learn some great things, and I'm gonna cure people, right? So I chased after a lot of those courses over a lot of weekends. And the interesting thing that I found is that when I came back with a new technique or approach, that 1/3 of the folks, we hit home runs. It's like, wow, that feels great, great results. 1/3 of individuals would be like, yeah, I got a little bit better, not overly impressed. And 1/3 of people would say something like, well, that's kind of subtle, right? And that's Wisconsin nice for. It didn't matter one hill of beans, they're just being nice, right? Like people in Wisconsin are nice, right?
They're being hopeful.
And it didn't matter what type of approach or new approach I'd bring to the clinic. And oftentimes there were quite different approaches. I'd have that a basic relationship. It wasn't until we understood that, look, maybe it's not a matter of one technique, maybe it's a matter of making sure that A, we find out what sort of things are going on with somebody. We list those sort of things because everybody presents a little bit differently, and maybe we prioritize our treatment and do multiple areas of intervention. We didn't talk about some other influences on shoulders, for instance, but this study in which they showed that people can recover from rotator cuff tears without surgery. They looked at hands-on work that included the collarbone joint here, that included the ribs as they attached to the upper spine, included the ribs, neck vertebrae, that whole area. There's oftentimes nerve irritation that's caused by upper thoracic spine, and that's that area between the neck and the lower back. Those areas can become quite involved. Teresa can probably attest to that, right? That area can send pain down the arm into the shoulder and wind up some of those shoulder blade muscles. So that's another area that can become problematic. So in an approach like this, there needs to be thoughtful consideration of all the sort of things that can contribute to it. Whew. That's a long time to talk. We'll take a pause. Yes.
I just have a question. You were saying that rotator cuffs can heal without surgery and with therapy, but how does a complete tear heal?
If I said heal, that maybe was an inartful artful way of saying recover.
Recover, okay.
Right?
Yeah, how does that happen?
So, the body has a way to adapt, right? So for instance, if we take outside of the musculoskeletal system, when people have things like partial coronary artery blockages, the heart builds new vessels around them, right? Similarly, when you have a part of the rotator cuff that's torn, you have other muscles to make up for it, right? Mm-hmm. So the first thing is that tear may not be what's causing that pain and trouble. It may be stiffness, it may be shoulder neck pain, it may be irritated nerves, it may be frank weakness. So the first presupposition is just because we see a tear doesn't mean that that's causing the problem. Mm-hmm. Because there's plenty of people with tears in the athletic population, non-athletic population, old and young, who don't have any problems. When there's a suspicion of that, then everything else you tend to prepare and overcompensate for. So you target those other rotator cuff muscles. You make sure that there's no stiffness in that shoulder joint. You get rid of the irritation that might be coming from the neck and upper back and the ribs. So you just create a nice environment for there to be better function, if you will.
And then for it not to get worse, is it possible it can get worse? I mean, if you're doing therapy and that will prevent it from being a complete tear if you have a partial tear? there things you can really?
I don't think we know that research. I think there's one thing, and I don't like talking about age-related changes, but one of the age-related changes is, just like everybody understands that skin gets a bit thinner over time, these tendons do tend to thin out a little bit over time, right? So sometimes people who exercise, their muscles stay pretty strong, but sometimes they over-exercise and they strain that tissue. People are under-exercised, they don't get enough stimulus there. Particularly past working years, right? If you're not doing a lot of reaching, pulling, and lifting, why would your body try to maintain all that connective tissue structure? The question is, can that tissue thicken up? Everything else around it functions better, and you can compensate better for it. What we're after isn't necessarily, does that rotator cuff look pristine on the MRI after treatment? Can I reach, push, pull? Can I lie on my side and sleep all night? Can I walk my dog? Can I do my garden and yard work? That sort of thing, right? That's the outcome we're looking for. Does that help?
Who's walking who?
They're totally fine walking until there's a squirrel.
Yeah,
They're
there's
totally fine walking until there's a squirrel, and then that's it.
squirrel, yeah.
You know, if I don't see it first, it's a big difference.
For sure. Was that clear? Yeah. I think it's fascinating, right? Particularly because of the emphasis on MRI findings early on, and now over time, we're understanding those discussions have to be elongated a little bit, right?
Yeah, I had an impingement surgery years ago, and they saw a partial tear in the rotator cuff, but he said, you don't need surgery on that now, though. So that was the right thing to do. And
it was a minimalist approach. That's good.
And just strengthen the muscles and keep exercising.
Perfect. I like that. Nice. All right. Other questions?
So if the pain isn't in the actual joint, but here, then we're talking neuropathy or tendinopathy, because it's not a muscle part, it's just the parts that make me lift my arm.
So pain in the side of the arm can be referred from the shoulder. It can also come from the neck. It can also come from the upper back. So the location of the pain here could be related to the shoulder, right? Most of the time when people have a complaint in the shoulder area, we definitely have to address that ball and socket joint. But here's the thing, if we just treat where the yowie is and don't consider the neck, don't consider the upper back, don't consider the other relationships, people's outcomes aren't as good. They're less satisfied, things don't progress. Something like that, right? We didn't talk about postural relationships, but certainly postural relationships of the neck and upper back and ribs, they're going to impact that too. That goes along with, hey, when we're treating those areas and being thoughtful of looking at the neck, upper back, shoulders, we're going to take a look at some of those relationships.
So you didn't talk, are there nerves in that capsule? You just said they're muscles? So if I have fibromyalgia, is that capsule affected by that?
Fibromyalgia will jack up all the nerves. It'll jack up the nerves in the central nervous system in the brain. It'll jack up the nerves that go from the spinal cord to that area, from that area to the spinal cord, and also the nerves in and around that area. It'll just excite all those nerves.
And when one is, the rest of my body goes with it.
Right. So that's under that irritated nerve section as a component of it. Within that, though, there can be other issues, right? So can you have more than one issue? Yes, almost always. All right. So this is the best part of the presentation. It's the 5-minute miracle. It's get a chance to have somebody present their problem shoulder, give you kind of an insight into how I take a look at, assess, and hopefully we'll get a 5-minute miracle to happen here. So Teresa's volunteering someone. So this might be really good, right? I mean, so here's the thing, like this This is always risky,
We're all
right?
gonna be like fighting to get to you.
This is always risky because, you know, I do 1 or 2 of these a month, sometimes 3, and, you know, most of the time we get a really good outcome, right? And, we've had some situations where we haven't, and there's really good reasons for it. But I think it's just good to get an idea of, hey, what's my thought process? And I talk out loud as I do this. And this does not fully represent necessarily what I do in the clinic, because we take a little bit more care and consideration on the front end. But we try to ask important questions and see if it's okay to proceed with a physical assessment, and I'll talk it through. So I think this might be a good case because this gentleman had a traumatic injury of some sort, right?
Yeah.
So remind us of your name again. Come on up if you don't mind. Perfect. If you would please. So here's the thing. We're gonna tape this. Do you mind?
Go ahead.
Okay, super. We're gonna get you to sign this here. If it works out well, we might use it. If it doesn't, we're gonna scrub it.
He's your movie star.
It's just a consent to use it for
Yeah.
It's the 11
Do you need me to move? Could you move this way?
So,
Can I move into the hallway area? And that way I'm on here, and then I'm not in front of your camera.
We're gonna move that a little bit.
yeah, I think the table can probably be right here. Perfect, thanks. All right.
Which would be right there.
So I want a pillow and also want to bring that
Okay.
out.
Congratulations, you are the next contestant on the table.
Nice. We can do this. We can probably do this right here. Pre-COVID, we had 32 individuals in this room once. It felt like an Allegiant Airlines. We had support staff that had to sit up on that counter. It was really cool.
It just shows how much pain everybody's in and trying to deal with. So we appreciate you doing stuff like this, sharing knowledge.
All right, so I'll plug this in here. So I don't miss any here. So Christian, take it away. You tell us what happened with your shoulder.
Sure. Was coming down some steps. They were a little bit wet, and next thing you know, do I talk into the camera?
Sure.
All right. Next thing you know, I just was going straight down, sliding onto the ground, and I skinned up my legs and shins pretty good. I really didn't even realize that I had any shoulder issues or that there's any. I don't remember grabbing onto anything, but I must have grabbed onto something to hold myself and keep from falling. And in the process of grabbing, something must have torn, because a number of days later I found that I couldn't do certain things anymore without extreme pain, and just other things I couldn't do at home.
Yeah. So feet first?
Yeah, feet first. I probably grabbed for a railing. I think I might have done something with this arm too, but this one seemed to heal where this one didn't. And that was probably 6 months ago. So.
Got it. You're right-handed?
I am.
Okay.
Yeah.
You're currently working?
Yeah. I recruit people for companies.
Got it. Okay. Fair enough. And what's your activity level outside of work?
I try to be active in terms of getting some workouts in or activities.
Okay.
So yeah, but since this happened, working out has kind of fallen off.
Got it.
Just because it was painful, and
Sure.
then but in the last couple of weeks I've started getting back to the gym more, and just focusing on some mobility things, and I've seen some positive results.
Okay. So the more he talks, the less I have to ask questions, and the less physical examinations I have to do. So I'm sorry. So tell me what you're currently experiencing, where you're feeling symptoms, or what you're feeling exactly.
So right on, there's general pain right here, but then if I use my arm a lot during the day, it'll just throb, and it will throb throughout the whole shoulder area. If I have to do something that involves reaching behind me, I might see something in the car, or my dog is doing something, I go and try to grab it. In the process of doing so, there'll be an increase, just a spark of pain that feels like it's on fire, and then it will be painful for the next 10-15 minutes, and then it subsides, and then I don't reach back as far anymore.
Fair enough.
Yeah, so that's kind of the main things, and of course, going up, I can't go much farther than that without it. Yeah. So anyway,
The other one.
Right on.
so.
Alright. So, you know, as people are telling me their history and their story, I'm thinking about stuff, right? Like, typically someone who has a traumatic injury to their shoulder that's worrisome, like they have that injury, immediately I felt it, and immediately I couldn't raise my arm, right? It was a delayed response for me, right? So that's adding to the fact that that is increased evidence that it may not have been one of those traumatic full thickness rotator cuff tears. But we'll do a physical examination, right? So I'm gonna be interested in two things. I saw him move already, reaching back, that looked stiff. This looked really stiff, right? So it didn't, you know, so I'm starting to think stiffness, right? But I'm gonna check his rotator cuff muscles thoroughly. We'll check each area as best we can with physical examination, right? There's limits to physical examination. There's limits to MRI examination. We take this thing called a medical history. We understand that, try to understand more about that individual. We start to meld that, do we need some sort of imagery? And then we get a physical assessment. And then even more importantly, we could do a trial treatment to see if we can influence that positively. A goniometer would come in handy here. What if you could grab one of those measuring devices from one of the rooms? Oh, perfect.
Okay.
You guys were looking out for me, awesome. Okay, so if you don't mind, I'm gonna have you just kind of stand just like this. This will be our starting point. And leading with your thumb, we'll start with your left arm. Just reach your left hand up and over. Okay, come on back down. So straight up, just straight up. There we go. Okay, and come on back down. Any troubles with that left shoulder? Great. All right, reach up with your right. We're gonna shoot some measures here, right? Like I'm gonna estimate that to be about 95 degrees. And 96. Painful there?
Yeah, I have to put it back down.
Okay, fair enough. And now up to the side like a snow angel, starting with your left, up as far as you can. Come on back down, and now on the right, I'm just gonna measure from behind you. Up to the side, keep it in that plane. You don't have to care. So you start to see him hike his shoulder up. He's losing steam at a little over 75, right? And now reach up behind your back with your left. You can reach up to his brow line. Come on back down. And up on the other side. He can't get his wallet out of his own back pocket, right? Okay. So we're starting to see a stiffness pattern. Reach across your body with your left arm. Yeah, right? So ideally he'd get to about 60 degrees. His elbow should go past his chin if he's looking straight forward. And on the right side, nothing doing, right? He's not yeah, we don't need to kill this thing. Okay, so I'm already building a good case for I'm thinking he's got some adhesive capsulitis issue going on, some profound stiffness in that joint, but let's make sure he doesn't have some sort of profound weakness in that rotator cuff. So you're gonna keep your elbows in, bring your hands out to the side, to the extent that you can. We're gonna challenge this muscle here. This is a series of muscles here, external rotators. Hold, hold, hold. There we go. Good. Leave that go. That's what we'd expect.
Stop on
On this side, you're gonna be okay here. Good. Good and strong. I mean, we could do this all day. He could do this all day. Put your hand in your tummy, bring your elbow forward. Right, so we're checking that subscapularis muscle. Hold it there. Don't let me move it. Don't let me move your hand. That's checking the front side of the rotator cuff muscle. Same thing here. To the extent you can, bring that elbow forward. Hold. He can keep his hand on his belly. No problem. Right, so that's good. I like that. He doesn't have full range of motion. I can't test him up here for strength, right? But we can touch some partial ranges. So just like you're in the middle of a horseshoe pitch, hold it there. Don't let me move it. You're right-handed. Hold. Don't let me move you. It's going to challenge a little bit more supraspinatus. Yeah, there's going to be some shoulder muscles in there, but that's supraspinatus. Hold here. Good integrity. I'm really happy with that, right? Good strength. To the extent that it can challenge a muscle here, actually we'll do it on the other side first. This is challenging the smallest of the rotator cuff muscles. Hold, don't let me move you. This is teres minor. Good. This is gonna test shoulder instability, give a little bit of pressure forward. No problem there, we wouldn't expect that to be a problem. I can't get his arm up to that extent, nor do we need to. But if you just hold your hand there, don't let me move you. Good robust strength. Like, you're probably surprised you're that strong in that position. I mean, you'd like to be overhead, right?
Yeah.
All right.
I thought it would hurt more.
Yeah. So the wheels are locked on this. If you don't mind, have a seat. You can keep your shoes on, no worry. Just lie down on your back.
I'll love your shoes over
All right. I'll be careful. All right. So what I'm going to do is I'm going to check out that joint capsule and see how much mobility he has. So if I block his shoulder blade, his elbow should come up to at least his shoulder level, probably to his earlobe. And right now he's got about 45 degrees of movement there. At his side like this, his hand should go back, like he's ready for a windup for a pitch. He barely gets past vertical to the ceiling, and he can't even get down. You see his shoulder start to lift, he can't even touch his belly button in this position, right? So that shoulder joint is pretty tight. On the other side, just to prove that, keep an eye on me. Probably two.
He's very trusting.
Moving around the snow, yeah, that'd be good too. Let your elbow rest as best you can. So if I block that shoulder blade, this ball and socket joint, you see how the profound difference in that, right? There's some other tests that can be done here, but they don't need to be done, right? I mean, we're doing a focal test. There's 60, 70 different shoulder tests. We don't need to do a lot of them. We're pretty confident we've got a adhesive capsulitis or frozen shoulder. High likelihood of that, right? So what are we gonna do about that, right? So that's a long game, right?
Not just 5 minutes.
Right? Here's the thing that's cool though, right? I mean, if we did a neck manipulation, that might loosen up pretty quickly. If we did an upper back manipulation, that might induce a change. I'm not gonna do that today, right? But it probably wouldn't be appropriate in this situation. But what I'm gonna do is just a little bit of work through that shoulder joint to give you an example of what some hands-on work might look like.
One motion that surprised me was throwing a piece of paper into a wastebasket, like that dude had, without, straight thing. That's cheap.
Got it. Gotta get you ready for the Office Olympics. Throwing a piece of waste paper into the wastebasket. So, ball and socket joint, what we're aiming to do is give a little bit of separation to see if we can encourage some relaxation in that joint. We might also do some contract relax actions through that muscle. Not sure which way we're gonna go here quite yet, but I'm gonna go for this. So I'm just kind of getting a handle of his upper arm, getting some stabilization of his shoulder joint here. I'm in a little bit of awkward position. This is a little better. As best you can. I'm not gonna do anything sudden, forceful, or tricky. And just doing this thing where I'm just seeing if we can't get a little bit more space in that shoulder joint. Comfortable so far? Do you feel like there's a little gap in that shoulder joint?
So are you doing muscle, you're trying to reduce the tightness in the muscle, you're relaxing the muscle like with your pressure points, is that what you're doing?
Yes, in a way, right? I'm trying to create a little bit more space in that joint. I'll show you on the spine model, because as you're watching, this looks like, what's it doing? It's not doing anything, really.
And remember to breathe.
So this is early on in a plan of care. So we'll talk about this a little bit. there's oftentimes generous use of some hands-on work to help calm things down, to help understand what effect we can do with some hands-on stretching. As time goes on, chances are there's gonna be more things that he's gonna be doing, right? At the end of a plan of care, what an individual generally needs to do is a couple things they need to do to keep the flexibility that they gain over a treatment plan and also to keep the strength. Different proportionality of strength or flexibility exercises required early in the plan of care. This is one of those things where early on we're gonna teach him some exercise to increase flexibility because he's gonna have to get after this. So. And what I'm trying to sense is, hey, did we get a little bit of a change and increased ability of the movement here? And I think we have. Now, part of this could be like, hey, he's realizing I'm not gonna do anything too obnoxious here. He's relaxing into it. Part of it is I might have induced a little bit of a neurological change, right? It used to be thought that when we do this hands-on work, that we're changing and pushing, pulling joints around, but what we're actually doing is changing local reflexes that keep muscles tight. Now what I want you to do is maintain yourself right here, don't let me move you. So we don't need to get an arm wrestling match here, we're just doing about 3 to 4 pounds of force just to activate these muscles. So I'm activating some of the muscles that are tight and resisting that external rotation movement, and now relax. We're gonna pause for a moment. Neither one of us needs to work really hard at this. We're gonna wait a few moments and we're gonna give us a little bit more mobility. Allow me to move you, allow me to move you.
So you're changing the muscle
There we
memory.
go. Yes, in effect. Maintain yourself here, don't let me move you, comfortable? Yeah. And relax. Allow me to move you. Maintain yourself here again, don't let me move you. So with someone in this circumstance with frozen shoulder, relax. We want to maximize any benefit we can from anything. The thing we don't want to do is flare this thing up, because if we cause aggravation, then his muscles are going to react to do what?
Lock up.
Tighten up, right? We don't want to ignore the flexibility of the ribs either, so this is a truncated examination. We would definitely be doing mobilization to the ribs, mobilization to the upper back. Again, there's only so much I can show in a short time. Maintain yourself here, don't move. We're gonna do one more of these.
I think it's interesting just to see the whole process you go through
And relax.
before you even start the therapy, the questions you ask, the things that you have the client explain to you. It's just interesting to see this whole process that you go through with your clients before you even start therapy.
Now as clinicians try to do a lot of stuff and do stuff too soon. Like, I'm a little older, more relaxed, like, okay, there's probably less things that we have to do, but those less things we wanna do really well, and we don't wanna do things we don't need to do. We don't wanna waste any time and effort. Have a seat if you would, please. All right. So,
Any residual pain?
first thing I'm hoping for is that, first do no harm, let's not jack this thing up, right? I don't need somebody getting jacked up because A, I don't want anybody down here to see, oh, he hurts people. Number two is, more importantly for him, I don't want him to have an increased reaction where those muscles are gonna wanna tense up. Now, I thought there was a pretty good response in today's treatment session, right? It seemed as if things relaxed a little bit. He's like kinda wondering, I'm not sure if that's much better or not, and that's cool. So I'm gonna have him come to standing, we'll just do a couple of those movements that he did before. We took some measurements, and we'll see how that is for you. Come up to standing, so we're looking for quality of movement, but we're also looking for total motion. If this guy doesn't have a tight ball and socket joint, he's not even at this top, okay? So all that other stuff that's going on probably doesn't matter. His muscle integrity is solid. He did not have he doesn't have a type of tear in his rotator cuff that's gonna limit his recovery. He's got more than enough strength in his rotator cuff. Awesome, workouts, good luck, all that kind of stuff, did that, right? But that stiffness has gotta go, right? So if you would, please go ahead and reach up, lead with your thumb.
Good job. Oh.
I don't know if that's significantly different. How does that feel up there though?
That's about the limit.
Yeah, my measurement is 103. I'll take that any day, right? A within session change like that, any day of the week. Up to the side, so, up
And
to
you
the side
never
like a
met
snow
before.
angel. This one is tough to get after. This one is gonna be one of the more stiff ones. I don't remember the range before, but we're at over 80, 83. I think we were down in the 70s before, right? 75, so that's up 8 degrees. That's a challenging one, right? Now, I don't know about reaching behind. He couldn't pick his own back pocket. He could start to think about it now. He could start to think about it. He's still not there, right? So all three of those emotions have improved. It's just adding evidence that first of all, he's a responder, right? Second of all, it confirms what we thought in terms of tightness, because that's kind of the direction that I was thinking about. I don't know across the body if that's going to be substantially different right now. I didn't have a good, you guys have a better look at this than I did. I didn't see this, but not sure, so.
Okay.
Right, yes?
I just have a quick question. Could the temporary use along with progressive slow stretching, which is what I think that you're going to wanna do, is like real slow progressive stretching exercises. Can he take some ibuprofen during the initial couple weeks of that, like maybe a couple or 3 times a day, or just before he does the stretches, just temporarily to help with some of the inflammation?
He could. I don't think we're gonna challenge this enough to drive up any inflammation.
Okay,
And I don't think inflammation at this point is causing this.
okay.
That probably occurred after the injury. Like, I'm theorizing,
This was
you
real
jam that
protective.
shoulder up,
Yeah,
abrupt inflammation,
yeah.
some muscle guarding, didn't use it so much, who knows what else? Maybe that's spontaneous, post-injury adhesive capsulitis occurred.
Yeah.
But, so there's a lot of treatment options with this, right? Conservative intervention like this is one of them, right? So if he can get better with this, then I'm teaching him how to work that, try to relax. We're monitoring that. We're teaching him to do what he can 2-3 times a day. This is a part-time job.
Yeah.
Recovering from this. I mean, I want to be straightforward on the front end of this. So that's how we're driving through it. So.
Is there a way to tell if there's tears in there from what you've seen so far?
So when I tested all the directions, you tested solid. You have
Okay.
way more rotator cuff strength than you're gonna need.
Okay. Good to know.
So it's not an issue of rotator cuff weakness in my mind. Could he have some tears in there? He could, because a lot of asymptomatic people do have tears. So
Right.
I like that. Good outcome, good, I think good prognosis, but this is gonna be a plan of care that, everybody asks, well, how are the treatments, all that kind of stuff. This is gonna be a robust plan of care to take him to where he needs to be, but if he doesn't get that early on guidance and then continue to progress that, it's gonna be tough, right? So.
That's his right arm and he's right-handed.
Right, so thank you so much, I appreciate it. Yeah, nice work.
You gotta be able to at least reach in and pick that ball up.
Gotta cover that copay, right? So. Super, so,
Get his wallet out.
right.
Put it in the left pocket, I guess.
So nice, so that was pretty straightforward. So when's a good time to consult to get for help? I think a big one is when pain interferes with your ability to sleep through the night. There's been a major study recently on sleep and the importance. I could no longer not pay attention to sleep research when two things came to my awareness. Number one, athletes, if they don't get good sleep, they're more at risk to get injured than the type of forces that they exert in training, right? Well, you can extrapolate that to include any adult, right? Secondly, there's a stage of sleep that's necessary for restoring and repairing muscles, bones, and joints. Fascinating stuff. And if you don't get good quality sleep, if you don't get enough sleep, you're not going to recover as fast. Okay, now we have to have the discussion. But also, I know that if people don't get sleep, the cortisol and stress levels go up, which means their pain levels go up. They are not a happy camper. Like, the first thing I have to do with people is help calm pain down. If they're not sleeping well, nothing's really good. And shoulders need a certain amount of flexibility for you to lie on your side comfortably in that position. to be comfortable, which we recognize. And once someone gets a certain level of flexibility, it tends to be that they can sleep more comfortably, and a major outcome. Secondly, if pain keeps you from thoughtlessly and fearlessly dressing, reaching overhead, gardening, all the things you need to do in your daily life, including exercise and sport. Some people play pickleball or whatever it is, right? Or working out. Some folks are fearful of losing their independence. It's tough for me to reach up, tough for me to wipe under my arm, that sort of thing. And you want somebody to stop worrying about it. If you keep getting repeated treatments or keep taking the same thing and it's not getting better, like we expect continued progress, and that's what people should expect week over week, session by session, to include strength, right? If you feel like you're spinning your wheels, it's a good time to consult. Obviously, any second opinion, you folks are open to that, just by the fact that you're here, and you don't want to worry losing sleep about that. Obviously, we talked about minimizing drugs, injections, and non-steroidal anti-inflammatories. This is one of those cases where we could have a discussion. Hey, you could pop that with a cortisone injection. That might offer an abrupt change. That might help proceed this further along. That might be a worthwhile consideration, right? So to Teresa's point, that is there something that could improve this, right? That might be something. There's risks to that. I don't do that. That's not my practice act, but that's a worthwhile consideration. If we're getting suitable progress, maybe not. If progress starts to slow, maybe that's a discussion we'll be having.
So what about dry needling for that?
Yeah, dry needling I think could be an option too, right? For this, the basics are hands-on mobilization, get that home exercise stretching program really tight and controlled. Let's see how that responds. We could put some needles in that. Different structures are helpful. Absolutely.
Do you
Absolutely.
do massage therapy then?
Not massage therapy per se, but we do deep tissue muscle work, massage work. So this is why I'm excited to drive to work every day, right? So modern evidence-based doctor physical therapy provides pain relief through joint mobilization and manipulation, including cracking joints. So we did a little bit of joint mobilization here, real gentle separation of those joint surfaces. That's going to give enough neurological stimulation to calm pain down, to relax muscles, and do a little bit of stretching. And provide that massage work that she asked about, deep massage work with tools to get that area loosened up. We can provide an exercise prescription that's customized to the individual, and that's tailored over time. It's an exercise prescription. It's not something you can pull off Pinterest. It's not a list of things that you get from somebody. And it's not just watching you do a bunch of exercises, but it's careful guidance and progression of those. And the big thing is developing a strength program. Now, when you talk to a physical therapist like me, strength means the ability of the muscles to work through its full range, right? Depending upon what Christian wants to do, he talks about weightlifting, and I'm sure he wants to get a pair of 45-pound dumbbells up over his head. He wants to get back to bench pressing, do some lat pulls, maybe some pull-ups, right? He's a strong dude, but his shoulder's not letting him use that strength, right? So whether someone's a weightlifter or not, we always want to point people in the direction of strength training, so that a couple times a week they can work to preserve their strength, maybe work to advance it. I'm a huge advocate of strength training. We can develop that program for folks. So at the end of the plan of care, dry needling, talked about that. So dry needling is simply the use of acupuncture needles. I'm not an acupuncturist, but we use acupuncture needles to help improve flexibility, to have some additional benefits that there's a whole range of things that can be helpful. We've got a whole packet on that. You might even receive a packet before you leave tonight on dry needling. It's a worthwhile consideration. Spoiler alert, insurance companies don't cover it. There's an extra charge. We try to make it affordable for folks, but it's a worthwhile consideration. It's not absolutely necessary, but it can help considerably. So, you found it helpful?
Yeah, after the first treatment with my neck, it was much more movable. I was in a little auto accident and whiplash, and I was amazed. That's how much better it felt.
Good, thank you.
So since I can't see the needles that you put in, like where do the electrode things go?
So they're usually on the top of the needle. So the needle doesn't
That's
get
what I
inserted all the way, so there's a little bit that's sticking out yet. So
Right.
pull it out, and it's just, the clips are just attached to that when we use.
So I don't know who that lady is over there.
Hi.
Tracy. Okay, so with the dry needling, then they put there's electrodes on it, and it actually does
So it
massage you
stimulates.
artificially. So it just keeps contracting those muscles that are really tight,
so that they are eventually forced to relax. And then healing can happen because all the proper healing chemicals can get there. When it's really tight, plus it'll increase your mobility and things.
She's doing the next workshop. Alright,
He's on the higher list.
I did, that is correct, is that right?
You're right, I would've stopped you,
Okay.
I would've stopped you. You're fine, you're fine. So we move people through this plan of care. Early on, we gotta control pain and inflammation, right? Secondly, we have to rebuild strength within that newfound range, and then we have to build durability over time. So everything that could contribute to problems, we wanna address, right? Sometimes it's a bit of posture, sometimes it's overuse, sometimes it's not enough use, whatever is needed, right? We have to steer that to the point where we get, like I said, at the end of a treatment plan, someone has a simplified program, a few mobility and pain relief activities they do on a regular basis, 2-3 times a week, some strengthening exercises so they can get after the things they want to do in life. Be ready for the snow shoveling, be ready to haul the deer out of the woods, whatever that is for people, right? And everybody's got their own thing. It doesn't matter to me, right? But that's what we want to do, kind of preserve that. So you've got some patient testimonials there, got some basic questions. Mark is one of my favorite guys, old school mechanic. They call him up when they get those old cars in with carburetors. All the young guys, ASC certified, they're like, carburetors, what the heck is that? So he was able to stave off a shoulder surgery for many years. He had a traumatic injury of his shoulder, fell down some stairs, pulled on it. And at the onset of treatment, I mean, this is the thing, like this was him when he came to me. Doc, can you help me? I'm like, I don't know. Tested his belly press was awful. Whoop, weak. I'm like, dude, I don't know. He's like, I'm not having surgery. All right, let's do it. Right? So we agreed early on, like, we have to have adult conversation. Like, I don't know if I can help you, dude. You've got evidence of a rotator cuff tear. Like, okay, I'm not having surgery. Okay, let's do it. Let's see if we can, and he fended off that surgery for a while, right? So that's what happens. Like, not every case is a home run for the rest of their life, but he was satisfied with his outcome. We'll get past these. So we you have an information packet. There's a discovery visit card, 30 minutes with a doctor of physical therapy. We can do all the insurance verification ahead of time. We can let you know what is going on with your condition at the end of that 30 minutes, what solution looks like to you if it seems reasonable for conservative intervention, what that costs in terms of your time and effort, and you leave that knowing what your best options are. So that's pretty straightforward what we do. And then we have conversations. Some people can use their insurance, some people pay cash. We just try to be as transparent as we can on the front end in terms of what that costs. Either way. So, before we go to the next step, questions, comments. You guys are really attentive. Christian was a great example for a 5-minute miracle, so I was happy about that. But I'm more happy that he now has a bit of hope for conservative intervention. The last workshop I did was, I think, a knee one, and the person sitting in front of me came in with a walking boot. I had to make sure, I had to test her out to see if she had a fracture in her ankle. She did not. She had a really nice result. The woman sitting next to her, who was really stoic, vigorous lady, she started to cry. She's like, oh my goodness, there's hope for me. I'm like, wow. We forget about that hey, some people are just looking for, is there something for me other than what's being offered, right? So one thing that I talk about is evidence-based practice. One of the talks I gave recently was about how to increase your, what's the term I use for it? Your ability to get the most out of healthcare, right? So evidence-based practice requires 3 things. Patient perspective, essentially patient education. Secondly, what is the skill of the practitioner? What is their training? I didn't train in surgery, right? I didn't train in medicine. So I'm biased towards conservative care, right? And I fully acknowledge that. And then what does the research say? When those 3 things line up, when you have a skillful practitioner, when you have a patient who's open to what they have to offer, and you have research to support it, and when there's a commonality there, your chance of a favorable outcome is pretty solid. there are individuals, and I have a fishy buddy, that he can't wait for the next surgery. He does not do very well when he comes here. Because he loves surgery. He does really well with it. He smokes, he doesn't take that good care of himself. I'm like, dude, you're pushing your luck. He still does well with surgery. I'm not gonna interfere with that. That's his bag, that's his preference. There's other people like old farmers who are like, I am never having surgery, right? And oftentimes those people do really well. Most people are in the middle. I want my choices, I want my options, and that's why I started the practice, right? So, anyway, where do we go from here? So we're pretty busy, and there's dates and treatment times or assessment times up on the wall. Here's Monday, Tuesday, Wednesday. I guess Tuesday there's not a lot of options. Looking into this is 2 weeks from now. Next week we're full up. Different providers. Any of the providers are awesome. I'm happy to see you, Dr. Jessica, Dr. Rebecca are happy to see you. Thursday, Friday. So basically, what you do is you say, hey, look, I want to come in for that discovery visit. Is it a Monday in 2 weeks, Tuesday, or Monday, Wednesday, Thursday, or Friday? And then you just choose your time, pull that off. You've got some information there in your slip that you can fill out some of your preliminary information, and then they can get working on some insurance information ahead of time if you do choose to use insurance. And we can get you on the schedule. So, you're welcome. I'm here for any questions or concerns. So what you do is, sign up times will be Monday, Wednesday, Thursday, Friday. In 2 weeks. If there's anything that opens up sooner than that, and you sign up, they might reach out and give you a call and say, hey, look, something opened up, we had cancellation.
So I can just put my name on that?
It's on the time too. Just a little bit. He was there with this when I came in.
I've had acupuncture in the past.
I was just thinking, everybody's got their drugs, so I just signed up now. I know, but I'm saying, I gotta get on the line. And then of course,
Let's look at a calendar. Yeah, he said 2 weeks.
Restroom in there?
Yeah, right. He's probably showing me right where it is. Next one, yeah, right there.
We kind of broke the ice for you.
I was up there this last weekend, and I was down by the end of the walkway, and it was warm enough with that summer sun. I took off my shirt and I tan So my son and his new bride will be using that next week. Yeah, they didn't quite have to read the plans, or they couldn't get it. Today we got somebody up there to insulate the foundation, so on the inside, so they're blowing insulation. So we're concerned about the pipes freezing in winter, so I think 2 o'clock.
Your dog, is it a service dog?
Yes, it is.
Oh, and for,
medical reasons.
oh, gotcha, yeah. Well, no, I just wanted to, are we allowed to pet him or no? Oh, gotcha, okay.
Thank you for asking.
Oh, absolutely, I know a lot of people want to right away.
Oh, I know.
Hi.
Because he's such a beautiful dog and he loves people too.
Yeah, I gotta ignore you though. You can't, while you're working, you're getting paid now.
Yes, exactly.
Yeah, he looks like a beautiful dog.
Thank you. Arlo looks amazing too.
Good to see you.
We enjoyed the presentation.
Yeah, you
Thanks.
too. Hi there. Yes, I had you come to this.
Here when you need.
I keep, just amazing. And you don't have hair. Nobody has to watch the needles going.
That's the best, yeah. I'm a needle phobe, so perfect.
Thank you.
Take care, Susan.
Right.
On the way here, I'm like, oh,